Welcome to Conversations in Health and Care Improvement, the podcast dedicated to transforming health and care through quality improvement. I'm Amar, Chief Quality Officer at East London, NHS Foundation Trust and National Clinical Director for Improvement at NHS England.
And I'm Pedro, Vice President at the Institute for Healthcare Improvement. And together we'll explore the latest quality improvement agenda, sharing insights, real-world experiences, and innovative strategies that can help enhance patient care and drive meaningful change within our health and care systems.
So whether you're a quality improvement professional, a leader of a health system or organisation, or someone who's passionate about improving health and healthcare, this podcast is for you. Join us as we dive deep into the challenges and opportunities we face in delivering the best possible care.
Now, let's get started.
Today, we are absolutely delighted to welcome Andy Knox and Jesper Ekberg to this episode. And we're going to be focusing specifically on population health improvement in this conversation with two guests who are going to share their wisdom and experience with us. So welcome, Andy and Jesper. And I wonder whether you could just say a little bit about yourselves, your background and your experience with our listeners to start us off. So Jesper, perhaps you could start us off.
Yeah.
Welcome.
Thank you for the invitation. It's great to be here and to begin my English again. I'm from Sweden, maybe some of you know, and it takes a few minutes before the fluently language is going, but let's have a try. Yes, Jesper Ekberg is my name. I'm from and I live here in Jönköping, which is in part of southern Sweden, together with my family here, 2 sons and a wife. And maybe you could say that Region Jönköping County has been my home pitch for 25 years. During those years I've had different roles here. So one of them was that I was the director for public health for 10 years. And I've also worked very locally with different preventive programs together with our municipalities here within our county. And now the lately years I've been involved in large-scale improvements here nationally in Sweden, and so right now I'm mainly working at a member-based organization called Swedish Association for Local Authorities and Regions. So I really like that that switch of local and national and go there between. So that's a little about me, I think.
So I'm Andy Knox. I'm a GP in Morecambe Bay up in the northwest of England. And I'm also Associate Medical Director within our Integrated Care Board, where my focus is really on population health, tackling health inequity, but also now improving culture, working on improvement and kind of recovery and transformation. So I do that currently 4 days a week now, just practice clinically 1 day from this month. It's a bit of a change for me, which I'm really loving.
I wonder whether we could just start off by helping our listeners think about the relationship between population health and quality improvement, because I guess the origins of quality improvement lay within service improvement, thinking about operational excellence and improving in processes within the hospital or care environment. How have you learned about the opportunity of taking that to the field of populations and the health and outcomes of populations? I wonder if you've got a story or an example you could share with us. Jesper, do you want to go first?
One thing I was thinking about was within that, population word, I think an important part is that it's not only, it's sometimes you get into that, average curse, and it's very much on the distributing. You look on the whole picture of health within a population. And so on connecting to QI, we often talk about the gaps, improvement gaps. And I think that's a key thing on population health, and looking at the outcomes of health and the distribution of them between different groups and different individuals and so on. So that's an important turning point for me, I think.
Yeah, for me, I think population health and improvement really exposes for us a question of value and who or what we value. So Mariana Mazzucato, the economist at UCL, she talks about how society is a manifestation of our values and who or what we value. And what QI, it's vital when we're talking about improvement that we consider our whole population. Because if we're not careful, improvement work can actually make it significantly worse for the people in our communities who are forgotten, or who we don't value, or who we don't think about, or who we consider too hard to reach, or who we've not really thought about because we've not listened to them, or we've not really walked in their shoes. So, for me, for example, I was really impacted by some work I did with the Gypsy Roma traveller community around breast cancer. So what we found in Lancaster was a group of women who were dying significantly earlier from any other women in our city from breast cancer. And when we drilled down into the data, it was particularly our Gypsy Roma traveller community who were having a significant disadvantage, both around accessing screening, presenting late and dying earlier. But I think if you don't take a view of the whole population, you can try and improve your breast pathway, but you don't necessarily work with those who are currently getting the worst inequity from the service. And you can also, if you're not careful, keep on designing things in a way that doesn't include them and so doesn't improve with them the outcomes that you want to see. And so although we'd known this actually about the Gypsy Roma traveller women in our community for quite some time, we'd never actually bothered to go listen to them or include them in the process of the improvement journey with us. But when we had the humility to shut up and listen and go to them on their terms, in their places, and actually find out why it was that we were getting things so profoundly wrong, we discovered all kinds of things about their community, their culture, their way of life, their feeling of exclusion, a whole load of institutional racism, all kinds of issues that we were not aware of, that we couldn't have improved unless we'd involved them and been with them in it and co-designed it and co-produced the solutions. And having done that and now profoundly changed our relationship and our way of working with them as a community, we're beginning to close that inequality or that inequity gap and see an improvement in outcomes for them and therefore the whole population. So I think for me, it really is about kind of, yes, data, yes, whole populations, taking an improvement methodology to make a difference, but actually making sure that you've got your values set right at how you do this work and having the humility to work with communities differently in this space.
I want to build on both of your reflections, which are very pragmatic. They're grounded on real experience. We see community organizations who intuitively improve everything they do, partly because their funding model tends to be year on year, so they have to, but they wouldn't be fluent in improvement in a technical way, in a necessarily systematic way. They're just intuitively good improvers. And you could say to some extent, we see that in primary care, where unless you improve what you do every day, it's really hard to survive. So primary care practices throughout the world are improvers. Some of them are very systematic about it, very intentional about it, and so on. Others less so, but still improvers. So when we think about population health, we think about citizens, not patients, so people who are living their daily lives. We see a function of public health that tries to have oversight of some things. We see very active engagement from community organizations and so on, but we don't necessarily see frequently all of those groups working together using, let's say, continuous improvement approaches to tackle prevention, to tackle management of conditions and so on. What should the future look like? And does improvement have any role to play in that space of partnership in integrated care with public health and healthcare delivery, primary, secondary, and other levels of care, citizens, and so on?
Well, one thing I'm thinking of is that many of us are trained in clinical microsystems. So maybe we're more on the other side here. It's maybe, what if we say community-based microsystems or something on the other side of the coin? In that case, healthcare is the guest or one part of the game, and you're on another improvement field, I guess, when you turn it, and then we don't have to say how do we reach them. Is that and maybe it's I'm not clinician, but what do you say, Andy? But often when we talk about from a healthcare perspective, it easily gets risk groups, risk populations, and so on. But as soon as we are visiting the society and the community, you can see all the resources as well, and we have to see it from that side also, I think.
Yeah, I think you're bang on there, Jesper. I think there is something about the improvement world, if I might be so bold, that is kind of built very much on a clinical model. And that's really understandable because we want to get clinical care right? It's absolutely vital that we improve clinical care. But there is something about, I think, taking a population health lens to improvement that potentially asks us to reevaluate the starting point from which we do improvement work and how power differentials are used in that space. So I think there are two really helpful thinkers who are worth engaging with if we're going to really take a health equity approach and a population health approach to improvement. The first is actually someone from the management world, in terms of kind of theory U and Otto Scharmer's work from Harvard, in just thinking through, actually, we know where we are and we know where we want to get to. And very often in the improvement world, it's about trying to build bridges across. But actually what Otto talks about is the need to unlearn, the need to let go, the need to suspend judgment, the need to actually have deeper humility and to listen at levels that make us profoundly uncomfortable, so that our starting place is from together with and being with communities at a very, very different level, a different kind of relationship to the one that we're used to, and then together with them beginning to co-create the design and the solution to the issue. So we can apply the improvement methodology, but we're not starting from up here, we're starting from a bit lower down, where we're letting go of some of our usual go-to solutions of how we think the answers need to be made, and we're starting from a different point. And I think Chris Bentley's work is then hugely important in this space in terms of talking about the integration. So it cannot just be led from within the health world. Jesper's absolutely right. This is about health being invited into conversations actually with local government public health colleagues, but also with communities and the community voluntary faith and enterprise sector. So for me, the work of tackling health inequity and taking a population health approach to improvement really requires a whole load more curiosity, a great deal of humility, and tons of compassion, because you've got to allow yourself to be with and hear and feel the pain of the communities who've been forgotten and left behind, and then together with them actually find the solutions to the issues they are facing, which then hugely impact on the things that you're seeing that are going wrong in your services as well.
My sense, Jesper, Andy, is the will and the desire to impact on outcomes for the population is growing and growing, even within the healthcare delivery system. People want to be able to influence those outcomes. Sometimes I get the sense that people feel like their ability to influence the structures that have an impact on health are limited. My way of framing this for people is that there are perhaps two ways to think about population health. One is to think about how we redesign and utilize relationships and influence to think about structures and plans and design at quite large scale, which not every one of us has access to or can be party to. But then there is another route, which is to do this work at much closer to the community, with the community. And then we can actually apply the methods and the tools and the skills that we've learnt and honed within clinical settings and really bring those and think about how we would adapt those to make small tests of change with our local community. And in fact, there is something really quite beneficial about applying an approach that's very local, hyper-local, I call it, where we can really understand the nuance and the assets in local communities and what really matters to them and do this work together. And I think the best improvement work is already done in that way. But I do think there's something for us to think about, and how do we give people agency that they can improve population health, even if, I'm a jobbing community midwife. And how do I improve the health of the whole population? I'm just one person. I'm just a clinician. I would need to engage all sorts of other parts of the system and community to be able to do that. But I think there are ways, aren't there? I'm really taken by your proposition, Andy, that we need to be more values driven in the way we do improvement. That's a framing I've not heard much yet. And I'm also keen to sort of explore with you both what might that look and feel like? What should people listening to this who are well versed in improvement be really thinking about unlearning and trying differently in the way that they practice improvement to be grounded in the kinds of values that we as a society should hold dear? What sorts of things should we be doing differently?
I think one low-hanging fruit is putting the question both from the population side and from the healthcare profession. What's in it for me? And I know that here in Jönköping we usually talk a lot on why. Do you say maybe frequent patients that come and visit healthcare frequently, many times? How come? Because we easily go on the symptoms each time, but what about the cause of the causes? What's behind this frequent visit all the time? And that usually is a good way of starting off, because when you talk about that, you kind of land into the social determinants of health all the time. It's about life struggles. It's not about this diagnosis or this symptom or something. So that kind of leads to how we can make bridges, I think, to people who can influence, for example, loneliness or isolation or other challenges in people's lives, I think.
Yeah, I agree with that, Jesper. And I think also, Amar, I think what you said before was really powerful about actually some of this is about hyperlocal relationships, grassroots communities working differently in our methodology and who we're choosing to work with and where we're starting our design work from, who gets to be included as part of that process. But you also said, but it also depends on strategic leadership change as well. And I think it does, because this is actually about how we use power and how we use power well. So there is a danger, I think, in some of the language sometimes around asset-based community development, that we make it all about, hey, communities, you go do this now, you have the power. But actually, we don't talk about the kind of societal structures which keep people in inequity or in poverty or in radical injustice. And there's something about, we don't just then push all the work onto them and say, come on, do it yourselves, improve, we'll kind of be alongside you as your cheerleaders. There's something about how we use our power to shift the values and the basis on which we build our leadership capacity and how our organizations function that comes alongside communities in their own power. So we recognize constituent power, and we have different types of power, but it's about joining those powers together. We have different perspectives, but it's about joining those perspectives together. And it's then about the kind of relationships, and it's about the proximity. I think part of the real problem, and I say this again and again in improvement spaces and in leadership spaces, is I think we've got a proximity problem. I think the higher up you go, and sometimes the more influential you become, or you become a director of improvement, or you become a quality lead, you spend all your times in meetings or around board tables with lanyards around your neck, feeling more important about yourself, but you forget on behalf of whom you're doing this work. And so actually being out and about in difficult conversations, in communities that sometimes make you feel really profoundly uncomfortable, that is where the kind of rub happens, because you are changed in the process. So I think that, yes, hyperlocal relationships, yes, power and strategy and change, but then there's got to be the proximity of bringing those two things together. And I think that's where the dynamic force for improvement really happens.
Well, if I just jump on there, Andy, I think as soon as you get out there and you take role on a local level, one of the things that I have noticed is that the project graveyard is too big. The project fatigue is one of the first things you notice when you get out there. That and then it's very much on the power side, as you say, Andy, on the trust side. Oh, here we go now again. Another person is coming out and want to launch a project with a slightly different name and so on. So maybe that's also a bridge to the quality improvement and science and so on that use the system thinking, go for the many small steps over a long time and all that kind of thinking. I think is a good bridge there.
But I think there's something so true in what you've said there, Jesper, which is that we have a huge amount of fatigue in the improvement space because we focus on the things we want to improve, sometimes with really good reasons, really good heart, really good desire. But we have forgotten to start with what really matters to our communities. And sometimes you've got to get the small wins and get people to build trust with you and to see that things can change. But if you just hit them with improvement projects after improvement project after improvement, and they just feel done to, they just feel like, oh, why should we engage with you? Nothing ever really changes. And I think you're right. It is back to that issue of power and in whose interest do we do some of this stuff?
You're making me reflect about the need for all of us as we shape a healthier future to develop and hone into our listening skills, to develop our humility muscle, to develop our skills around co-design and co-production if we are truly going to be kind of sitting alongside people and addressing the question of what matters to them, starting by asking it. You're also bringing to my mind this phrase that we've been using and reflecting with many groups around an approach that could be two ways in the two extremes, mile wide, inch deep. So we're going to fix the health of the population, or inch wide, mile deep. We're going to really understand the issue and go really deep so that we can partner with communities and move this dial in a different direction. And I couldn't stop myself thinking, Andy, particularly based on your reflections and Jesper's on your book. You've used a provocative title of Sick Society, and then underneath there's a strap line around reimagining how we live well together. And every title of every chapter of your book starts with the word love. Can you just tell the podcast audience a little bit about the why you were inclined to write a book which is packed with your stories from clinical practice, from community work, and so on, and what you hope the book will bring in terms of dialogue for the people that read it?
Yeah, I think I've been so provoked both as a clinician in my own clinic room and then kind of looking more widely at population health that our society is really sick right now. I think both in the UK and actually across the Western world. And the inequity gaps are widening. There is huge social injustice within our communities. And the overwhelm in the NHS right now is that people are coming through our doors in increasing numbers with increasing dissatisfaction, burnout really high amongst clinicians. And we just keep on after the same model. And it's not going to be able to deliver what we need it to in the future. If you want to find a different answer, you've got to be brave enough to try something new. And what I'm suggesting in my book is that actually profoundly at the heart of every human being is the need to know that you are loved, that you are seen, and that you belong. And actually, if we could recreate a health and care system which fundamentally enable people to know that they were loved, that they were seen, and they belonged within community, that we could build a society based on a very different value set. Value. What does our economic system begin to look like if love is at the core of it? What does our education system begin to look like if love is at the core of it, rather than league tables or Ofsted reports or all the other things which shape it right now? What does our political system begin to look like if love is at the core of it? And so that's my book really is can we reimagine a society in which we put a very different value set of love and kindness right at the core of every part of our life together and see what we could actually build as a future in that space.
In my career, Andy, I think I've rarely heard the word love used
Mm.
in the world of health and care. It's interesting that love is an explicit value for the Institute for Healthcare Improvement. I don't know any other organisation that has it as one of its core values. But I do think I've seen it and felt it in certain types of work, and the types of work in which I've seen it most strongly, this idea of being loved, being seen, being heard, I think comes through for me in the work of improvement more than in any other kind of work that I see.
Mm.
So I really think there is an opportunity for us to bring those to be the sort of driving force and the core principles for what we do and how we improve in the future. But it does mean I think we start from a different place. We have to start from a place of discomfort, as you describe. We have to start from knowing where the disparities and the inequities are. We have to start from who is in the room being very different. And we probably have to start by rethinking some of the ways we might traditionally have gone about quality improvement. I guess
Mm.
I'm keen sort of to understand a little bit, Jesper, about how you've taken some of these principles and tried to bring them at scale, because that's another real challenge. How would you do this across a region, or now you're doing this across a country?
Yeah, well, one of the things that I know in quality improvement, we talk a lot about bright spots, and driving from those and find the ways to scaling up. And one or two fields or examples I could tell you about is that obesity is also in Sweden a big challenge, and um, we have been close to one of our counties up in north, Västerbotten, that has been holding on for a workway for, I think it's almost 15 or 20 years now. So it's so long from a project you can come. And what they did was that they told themselves, what if we, each one of us, do a little more of what's good? Instead of doing something completely new, they said that what if maternity health, what if preschool, dental care, and a few, actors there said. And what they did there over time now is that they kept holding on to the same system year after year. And, for the first 3 or 4 years, we couldn't see so much change on the overweight and so on. But after, 5, 6, 7, we can see a decrease. And now they're best in the country on decreasing overweight among young adults and the young 4-year-olds as well. So it's something on that also, on the timeline when we talk about population health, I think. And another, I know I told you, Pedro, about this wonderful bright spot down in Malmö in the south of Sweden, which is a very multicultural place in Sweden. They said, we don't have the strength or the money to do it wrong one more time. We have to start, as you say, on the trust and on the love side. And why not see what we already have when we talk about health and a good life for our children? So they said, what if we say if our schools also is a activity house? It's not only a school, it's an activity house. And from that moment, activities were planned before school, during school, and the message to the families and the parents was that school don't end when the education part is ended. It ends maybe 6 or 7 in the evenings, because that's when all the activity happens, and it's all free. And talking of love, what you said there, Andy, also, when they launched these activity houses, the first the leaders did was to call each parent and just to say something good that their child had done during that day, which I think it was a perfect activity just to what you just spoke about, Andy, there. This is building trust. You're welcome whenever you want to.
And that's the power of partnership as well, right? Actually saying we can't do this on our own in health. Like, we need partnership with schools like we've never needed partnership with schools. We need partnership with local government, with community groups, with whoever, that we're not going to actually see a big improvement in the health of our population if we try and do it from within the health service. We're going to do it in partnership and in integration and in collaboration with so many friends across our communities. It's actually about finding the people in our communities who all care about this together, who almost form like an eldership and say, we're going to take care of the communities together, and we're going to take responsibility for the health and well-being of every single person and ensure that every person knows that they are loved and seen and belong here.
Yeah, and just I had a talk with our the director for our child health here in our county, and I was amazed that there was, I think, 3 families in the whole county that didn't visit childcare. You know, okay, so what do we do with that opportunity? And that's why we kind of build on that child health bubble and we created something called family centers, where we have social care connected, and we have a preschool, and we have maternity health and so on. So why not build on what's already existing and so on?
I'm keen, Amar, as we start to kind of transition towards the end of our conversation, to understand Jesper and Andy's hopes. So as you think towards the future, and based on your reflections during this podcast, what are your hopes for the future of population health improvement?
I think for me, if you don't mind me just dipping in, Jesper, is for me, I think this is becoming already and will become more. And I hope it becomes a really radical social movement. I think this is that, you look at what's changed in society in the last 150 years, the really, really big ticket items like women's rights, civil rights, LGBTQ plus rights, climate justice, the stuff that's really caught the imagination of the people. It's all been led by social movement. It hasn't been led by someone powerful at the top saying, oh, yes, let me make a change to that big issue of justice. No, it's become something in the people together. And I really love the work of Valérie Fournier. She's a great thinker at Leicester University, and she talks about the 3 stages of social movement. The first is you've got to create outrage, or you've got to allow yourself to engage with a deep sense of injustice. You've got to care about it, compassion. You've got to care deeply enough about the issues of inequity in our society to want to make a change. But the second is you then challenge inevitability. It doesn't have to be this way. We don't have to see this level of inequity or this level of social injustice in our society. And we don't have to just accept that it's going to carry on, that there's nothing we can do about it. There are loads of things we can do about it. And so the third thing is you then build moral alternative economies. You try new stuff. And for me, that is improvement 101. You try new stuff, or you take what is already good and you build on it and you do more of it and you improve it and you get better. And I think for me, this bringing together of population health with improvement allows us to say there's something that's fundamentally wrong that's motivating us all to want to change it. We're challenging the inevitability that it has to be this way, and our understanding of improvement tells us it doesn't. And so we're going to build on that knowledge, and we're going to build a community of improvers who are going to be a social movement and massively change health outcomes, particularly around health inequity and improving population health right across this country, Sweden, wherever it is that we find ourselves.
Population health, I hope it to be an everyday work thing, not something you do, now because of this and that, we have to prioritize this, That's when you get all that variation all the time. It's an everyday work thing. And not only one profession's business, as me and you, Andy, are the population health workers. No, it's all of us.
Fantastic. Thank you both so much for joining us and for bringing your insights and wisdom and experience to help us think about the topic of population health improvement. And thanks everybody for listening in to this episode of Conversations in Health and Care Improvement. We hope you found some valuable insights that you can take back into your own work, thinking really about how we can create that discomfort, how we can move to become guests in our communities and really start with a different set of people and listening to conversations that make us feel that outrage that you described, Andy, and then challenging, and then offering some alternatives through the route of quality improvement to be able to really make a difference for people's healths and lives.
And remember that quality improvement is a journey, not a destination. We encourage you to take the open invitation that Jesper and Andy made, the ideas shared here today, grounded on love and trust and equity and so on, and explore how they can fit into the unique context that you work in.
And if you've enjoyed this episode, feel free to subscribe, rate, review us on your favorite podcast platform. Your feedback always helps us reach more and more people with the insights and experience of the guests that we have on this show.
Join us next time as we tackle another important aspect of quality improvement. And until then, let's keep striving for excellence in health and care and for ongoing daily work integrated population health improvement.